Dr. Sherif El-Refee his talk will be about challenges in diagnosis and management of delayed puberty. Dr. Sherif is a consultant and head of Paediatric Endocrinology and Diabetes at the Imperial College in London, and now we the Diabetes Center in Abu Dhabi branch now. The presentation is about delayed puberty.
Good afternoon, everybody. I am Sherif El-Refee, and I'm a consultant pediatric endocrinologist currently practicing in Abu Dhabi. I would like to start by thanking Professor Samah and the organizing committee for giving me this opportunity to talk to you today about one of the common complaints we face in a pediatric endocrine clinic, which is delayed puberty. So I would like to remind you about this very, very important slide for the hypothalamic pituitary gonadal axis. As you know, the hypothalamus produces the gonadotrophin releasing hormone, which stimulates the pituitary to produce the gonadotrophins, LH and FSH. Both of those stimulate the gonads to produce testosterone in boys and estrogen and progesterone in girls. So as you would imagine, any defect along these three levels will results in low sex hormones. And also you should imagine that if the problem in the hypothalamus or the pituitary, beside the low testosterone or estrogen, there will be low LH and FSH. But if the problem here in the gonads, due to the feedback mechanism, the pituitary will produce more of LH and FSH, so therefore there will be high. And this is actually the first step when you are trying to locate the site of defect in case of low sex hormones in delayed puberty. How about the concept of puberty itself? It is slightly different. In the view of parents, normally they define puberty as starting of menarche in girls or nocturnal emission in boys. However, we should remember and remind them that puberty is a process and it takes time. And the first sign of puberty in boys is testicular enlargement to 4 milliliter, and in girls is the breast buds, followed by about 6 months by development of pubic hair, and another 6 months for axillary hair. And through all this process, the growth will accelerate. And the end of puberty in boys is the facial hair, and the end of puberty in girls is the menarche. It's always important to remember this sequence, because abnormal sequence doesn't mean normal puberty. So, for example, if you see a boy or a girl who have pubic hair but no breast bud or testicular enlargement, that's not central to puberty. It could be just adrenal puberty, or what we call adrenarche. Why puberty is important? Of course, because it is the development of the secondary sexual characteristics, and it is the start of the fertility, but also because sex hormone promote rapid growth. It works with the growth hormone. But another one which we used not to remember a lot is the bone health. Without sex hormone, we will end up having osteoporosis. This is very important because particularly in children who have severe developmental delay, and parents will come and ask for, why don't we delay puberty? Of course we can delay puberty, but you have to keep in mind that they will end up having osteoporosis, because bone accrual happen mostly during the pubertal process. And at what age puberty starts? It starts at 8 years in girls or above, 9 years or above in boys, but maximum in girls 13 years and in boys 14 years. So that is the definition of puberty, which is absent of first sign of puberty, which is the breast development in girls beyond the age of 13, or absent testicular enlargement in boys by age of 14. Also, I wanted you to be aware of this stalled puberty when puberty starts and then stops. And this is normally not very good news and normally indicate long-term treatment, and I'll come to this later. Again, as I mentioned, pubic hair only is not true puberty. Again, I am back to this pathway. So imagine now there is a defect in the hypothalamus producing the GnRH. In this case, as I mentioned, we will have low sex hormones and also low LH and FSH. And this is the most common cause of delayed puberty. And most commonly, it is transient, is not long-term deficiency. And this happens in constitutional delay in growth and puberty, which is mostly genetics, and it is simply just delay puberty, but puberty will kick on later. But also happen with excessive exercise or with systemic illnesses, as shown here. Also in drug abuses, this can cause functional or transient deficiency of GnRH and delayed puberty. The constitutional delay in growth and puberty is the most common cause of delayed puberty. And it is autosomal dominant, so it is genetics, and normally it is autosomal dominant, and normally father give it to their boys or mother pass it on to their girls. And it is transient defect, but because it is transient deficiency of GnRH, sometimes it is not easy on the spot to differentiate it from permanent gonadotrophin releasing hormone deficiency, or what we call Kalman syndrome if it is associated with anosmia. This permanent deficiency, we only think about it after age of 17 if puberty did not start. So what should we do in cases suspected of having constitutional delay in growth and puberty? Is mainly serial observation, as I mentioned earlier. We try to give psychological support, particularly to boys. Boys don't accept delaying puberty like girls. In most cases, there is no need for any intervention unless the child is severely psychologically affected by the delay of their puberty in comparison to their peers. And if that is the case, sometimes I don't normally recommend it much. So in exceptional circumstances, I start small dose of testosterone or estrogen for 3 to 6 months and reassess later. And the bottom line in any treatment with sex hormone is low dose. Start by low dose, because we don't want to give high dose, which will accelerate bone fusion and the child ends up with being short. And then how about permanent rather than transient deficiency of the GnRH? Again, in this case, you expect to see low testosterone or estrogen and also low LH and FSH, hypogonadotrophic hypogonadism. And it is rare, and in about 50% of cases, It is associated with anosmia, lack of sense of smell, which is called Kallmann syndrome. But another probably quarter happened without anosmia. And in few cases, some syndromes like Lawrence-Beadle's and the Brother-Willie syndrome. We start to think about this if no pubertal changes by age of 17 or if puberty started and then stopped. And normally there is negative family history, but in most cases there are a clue of some congenital anomalies. We mentioned anosmia, but also hearing loss, cleft lip and palate, hand deformity, renal agenesis, and also because it is congenital, then the child sometimes born with small phallus or undescended testicle. And even in Kallmann syndrome, there are about 10 to 20% of cases it improves without treatment. And as mentioned early, it is difficult to differentiate it from the transient form of GnRH deficiency, and serial observation will tell you one way or the other. The other conditions where there is hypogonadotrophic hypogonadism with low LH and FSH apart from the hypothalamus is problem with the pituitary gland. And normally the LH and FSH deficiency is associated with other pituitary hormone deficiency like central hypothyroidism or central hypoadrenalism. And sometimes there will be some craniofacial defects, midline defect particularly, from the acquired causes tumors, which is about 5% of all cases of delayed puberty, but also trauma or apoplexy could be the cause. So history will tell you and shed some light on the underlying mechanism. Then how about if there is a problem in the gonads, testicles, or the ovary? And in this case, as mentioned early, due to the feedback mechanism, you will get picture of hypergonadotrophic hypogonadism with raised LH and FSH. And causes for that is mainly congenital, particularly in girls. Turner syndrome is the most common. In boys, Klinefelter syndrome. Other rare causes like anorchia or vanishing testicles, or some of the disorders of sex development where there is defect in the synthesis of the sex hormones. Chemotherapy and radiotherapy and trauma and surgery or autoimmune, again, is not very common, same as in the case of gravity. So, what should we do when we are faced for a child with delayed puberty after age of 13 in girls or 14 in boys? History of chronic illnesses, because they said this is a very common cause. Congenital anomalies like Turner syndrome, Klinefelter, should ask about smell in Kallmann syndrome, and family history of delayed puberty in constitutional delay, drug abuse, history of chemotherapy, or history of trauma to the gonads or the head. And also, we should look for stalled puberty, where puberty started but stopped at some point. And this is not a very good news because the underlying cause will be either tumor or chromosomal abnormalities. And as regard examination, we should look at the height and span for Klinefelter syndrome, any signs of other syndromes, and to document the delay in puberty with testicular size less than 3 ml or length less than 2 centimeter, and absent of breast bud. And this is the famous orchidometer, I'm sure you're aware of, for measuring the testicular size. What initial investigation we should do? Bone age, mainly to predict the final adult height. Then we do blood tests to exclude any systemic illness, including thyroid function test. And the most important test is the LH and the FSH and the testosterone or estradiol, because as mentioned earlier, this will help you to locate where the defect is. So therefore, when you get high LH and FSH with low testosterone or estrogen, you should think about problem with the gonads itself, whether it is maldeveloped or damaged, like in chromosomal abnormalities, like anorchia, autoimmune damage, or chemotherapy. And this will be, you will have an idea with the history of other congenital anomalies, but you should do karyotype to exclude Turner or Klinefelter. On the other hand, if you have low LH and FSH, then you should think about problem with the hypothalamus or the pituitary, the transient cause, as we mentioned, the constitutional delay and in systemic illnesses, or permanent, where there is problem with the pituitary, whether congenital or acquired as trauma or tumor or infiltrative diseases. In this case, we should think about doing MRI brain and pituitary, particularly if there is neurological signs. And we look for the pituitary and also for the olfactory region as part of Kallmann syndrome. We should think about genetic when there is permanent GnRH deficiency after age of 17, and we can do some genetic tests for Kallmann syndrome, and we check for prolactin and IGF-1 to exclude other. So if I move now to the treatment, of course we need to treat the cause, particularly in a transient form like hypothyroidism, systemic illness, and also in cases of constitutional delay if needed only. Other than that, we normally observe and we should consider 6 hormone replacement permanently after age of 17 or 18 even, because before that age it's difficult to be sure that this is a long-term problem or just a transient problem, unless it is very obvious, like case of Klinefelter or Turner syndrome or chemotherapy or trauma, apoplexy, this sort of things. So what should we do with boys? Of course, we should give them testosterone. And it depends on the availability, but the most common is the testosterone enanthate or cibionate. And we should start by a small dose, like 50 milligram monthly for 3 to 6 months. And then frequently we stop for 6 months and reassess, because if it is transient, like constitutional delay, or in the 10 to 20% of cases of permanent gonadotrophin releasing hormone deficiency, it can correct itself spontaneously. But if there is no good progression, we repeat another cycle, but if no progress after 2 cycles or the child is older than 18, then we should start full replacement as on a long-term basis. But just as a word of to be cautious about, never use long-acting testosterone for starting or inducing puberty. So lipido is a maintenance testosterone, but not for initial induction of puberty in boys. And our aim, if we start long-term replacement, is to mimic the normal puberty, which should be replacing over 2 to 3 years, which is roughly 1 tonner stage per year. Small dose initially, increase every 6 to 12 months from 50 to 100, then 150, 200, unless we reach 250 milligram per month. Then for 6 months, then we can think about maintenance with long-acting lipido, which can be taken every 10 to 14 weeks. About girls, again, it should be small dose and it should be slow, mimicking the normal puberty over 2.5 to 3 years. And try not to increase the dose very quickly, because if you do, you will promote epiphyseal closure and the child will end up being short. But also importantly, the breast shape will be a bit strange if you increase the dose quickly. In girls, it depends on the availabilities, but for estrogen replacement, there is a patch, matrix patches, or oral medication. It depends what's available locally. And once we complete the pubertal development, we should start thinking about adding progesterone to induce monthly period. And the patch is generally better than the oral medication because more physiological, and it has a greater actually effect on the uterine length and the breast development, and also in the bone density. But the problem with the patch is that it might fall, or the child might not accept it because it is visible, and some children respond better than the others. And the tablets is easier to use, and we have much longer experience with it, particularly in the UK. But actually, the problem is its cost is very expensive because it is specially manufactured, because you have to start by low dose of 2 microgram. And I repeat, microgram, not milligrams, like normally available in contraceptive pills. And this is a table, and if you want to take a picture of this, assuming without my picture, and then this is the protocol we normally use for the patch or the tablets. And again, it is small dose, increasing the dose every 6 months slowly. And I would like to finish by reminding you of the stages of puberty, tonner staging, and I'm sure you're all aware of the breast development. There is no tonner stage. 0 starts by 1, which is the prepubertal, then a little breast bud slightly enlarging and more enlarging to the adult shape and size, which is tonner stage 5, breast stage 5. Pubic hair, again, 1 for none, little bit more, stage 4, where there is pubic hair but not extending to the thighs, and tonner pubic hair 5 when it is full pubertal involving the thighs. And same here for boys, regarding the pubic hair and the penile length, stage 1 to 5. To conclude, the cutoff age for delayed puberty is 13 years in girls and 14 years in boys. Starting and then stopping puberty is not very good news. The most common cause of delayed puberty is constitutional delay, and it will need only reassurance. Rarely we need to induce puberty by short course of sex hormones. The gonadotrophin-releasing hormone deficiency should be thought about when puberty is delayed after age of 17 and didn't start spontaneously, because it is not easy to differentiate it from constitutional delay of growth and puberty, and time only will tell. And constitutional delay is the most common cause of delayed puberty, and is more common in boys than girls. You should always think about nutrition and chronic illnesses. Turner syndrome and chemotherapy and trauma, where there is problem with the gonad, happen in about 13% of the cases. Less common is the Kallman syndrome or idiopathic. And a word of caution, never use long-acting testosterone for puberty induction, and the general rule is to start sex hormone in low dose and go up very, very slowly, and never ever initiate progesterone before full breast development. And this is a problem, in fact, because I know in some countries there is no estrogen preparation without progesterone, which I know is a big challenge, but you have to start by estrogen only until full breast development, and then consider initiating progesterone. And thank you very much.